Hello everyone and good evening. I am Dr. Amit Thaukar from the Medical Services of Sun Pharma. On behalf of the organization, I extend a very warm welcome to each one of you and I thank you for being a part of this scientific activity. At Sun Pharma Urology Division, it is our continuous endeavor to facilitate learning opportunities by involving top experts from the field of urosurgery. Meet the Icon is one such initiative wherein we connect you to the experts in urosurgery. We have conducted several such programs in the past and we thank you for making this educational meeting a big success. It was based on your feedback that we decided to incorporate more practice-oriented topics this year. Hence, we approached Dr.V. Chandra Mohan, who has always been at the forefront when it comes to academics and learning. Our speaker for today, Dr. V. Chandra Mohan, is a consultant urologist and managing director of Preeti Urology and Kidney Hospitals in Hyderabad. He did his MBBS from Osmania Medical College in Hyderabad and MS from the most prestigious All India Institute of Medical Sciences. He completed his MCH, that is super specialty training in urology, at the another prestigious premier institute, PGI Chandigarh. During his training, he published international papers and attended various national and international conferences. He also finished his exams for the membership of Royal College of Surgeons at Edinburgh, UK. He received gold medal from Honorable Mr. Jyoti Basu Garu in 2005 for DNB Urology. He launched the first laser technology for stone removal along with flexible ureteroscope in Andhra Pradesh. The disadvantages of ESWL and evasiveness of PCNL can be avoided by this technology of retrograde intrarenal surgery, RIRS. The technology is already replacing ESWL and PCNL in Western world in appropriate cases. Dr. Chandra Mohan has conducted more than 4,000 RIRS surgeries over the past 10 years. So any guesses on today's topic? Well, the topic for today's discussion is RIRS from basics to the right approach. On behalf of Sun Pharma and all the participating urologists from different parts of India, I extend a very warm welcome to Dr. V. Chandra Mohan and I thank him for taking time out on a busy Tuesday evening here in Hyderabad. Over to you, sir.
Hello, good evening everybody. Thank you for the introduction. As you all know, retrograde intrarenal surgery in the recent past is used more commonly for the renal stones. Today, we will discuss from the basics to the appropriate approach. That means which cases to be selected, how to cost effectively do the RIRS procedure, how not to damage the scope, how to improve the stone free rate, what are the various types of the scopes, what are the various types of the laser missions, what are the various types of methods of stone lithotripsy, and so that patient gets maximum benefit. With this introduction, I will continue. You can text your questions online so that at the end we will take up the questions and try to give the answers. Now coming to the RIRS, way back 1964 only Marshall used flexible ureteroscopy, but it took a long time. Again in 1990, Michael Grasso has brought into the clinical practice. Now 2006, digital scopes have come. This is the way the flexible ureteroscopes have come into the practice. Now I divide my topic into anatomy, indications, instruments, accessories, sterilization, laser settings, technique, approach to simple cases, approach to complex cases, and complications. This is anatomy. Now, when you look in difference between the PCNL and RIRS is, in RIRS, we go through the ureter into the kidney and then go into the each calyx. That means we are not much concerned about the parenchyma, but we are concerned about the pelvic calyceal system road. That means IVP, RGP, reconstructed CT, these are more important. We don't go into the parenchyma in RIRS. We need to know the ureter. pelvis and orientation of the calyces in relation to the kidney. That is more important than the parenchymal position. Now, first urethra, anytime if you want to pass, even though the flexible ureteroscope is small, access sheath can injure the urethra if the stricture is present. Assess the urethra always. How do you assess? You can pass simple cystoscope to assess the urethra or the prostate and the bladder also. Very important. If not, ureteroscopy can assess both urethra and ureter. Which ureteroscope? 6 by 7.5. Now, if you see the prostatic angle, as you all know, when you do cystoscopy, you bend down and go into the urethra. That means if you are using access sheath, it has to take some curve of 70 degrees to go into the bladder and then go into the ureter. Keep it in mind. High bladder neck, sometimes you will not be able to insert the access sheath. What will you do in such cases? Because you have done cystoscopy, because you have done ureteroscopy, you have an idea that this bladder neck is very high. In such cases, you load the access sheath over the ureteroscope. With that, you go into the bladder so that you can avoid this high angle blind insertion. Otherwise, it will buckle. So that's where anatomy is very important. Sometimes stricture can cause damage to the urethra if you go blindly. So always when you do start a procedure, gently have a look of the urethra and bladder neck. Now coming to the ureter anatomy, this is a standard. There is no need to go into the detail, but two important points in relation to the RIRS are, one is narrow part, another is thin part. Narrow part you cannot pass. Intramural part is narrow, whereas thin part is top PUJ. If you are using basket and coming out carelessly, then it may avulse. So these two parts are dangerous. When you are going with access sheath, if you forcibly hit the intramural part, muscle will tear and it forms stricture. Management of these strictures is difficult. In the upper part, you need not put the access sheath, but when you are coming out with stone, be careful. These are the two important anatomical factors we have to remember in relation to the ureter. One important question everybody asks is whether to stent the case or not. This is actually many times discussed, but in view of the junior sitting in front of us, most important point is all Indian ureters average are 9 French to 10 French. That means if 8 by 9.5 or 6 by 7.5 ureteroscope goes easily into the ureter, that means you can try access sheath. Simple answer. How will you try? Patient will be under short GA. Try once. If it is very tight, put the stent and come out. What type of stent? Any stent. 3, 4, 5. How many days? 12 days. Why? Maximum dilatation comes. You don't want to fail again. I hope it is clear. Ureter should be assessed with ureteroscopy 6 by 7.5. If it is very tight, do not attempt. That is one indication for stenting. Second indication is when you are doing a complicated case, large stone, where you need to take out the fragments again and again, then stenting is required. Now, these are the theoretical aspect of the sizes. Remember, intramural part as well as the PUJ, these are the two areas where it is narrow. Now, sometimes when you see the ureteric orifice, you feel that it is very small. Think once again putting the access sheath in such cases. You all know that oval, easily raisable with guide wire, like this you see. If the guide wire is passed, if it is raising, that means it has space to accommodate your access sheath. If it is not raising, it is on the flat, goal fold ureter, careful, put a stent and come out. Don't try to force because edema of the ureter lead to two problems: postoperative sepsis, postoperative fragment retention at the edema region. Obviously, small fragments may get stuck at lower end. Now coming to the difficult places, like more than 50 years if you are tweaking RIRS, large prostate gland may be there. One thing is bladder neck high, other thing is, if you might have seen, when large prostate is there, orifices will not be seen. What will you do? You have to do TURP. Without telling the patient, how will you do TURP? So keep that in mind. If large gland is there on PR, if the prostate is too high, tell them that I may resect a little bit at bladder neck and access the ureteric orifice and then go in. If it is a large stone, choose PCNL. If it is a small stone, have this thing in mind so that you will not do mistake. Sometimes unexpectedly you see a kidney, if you have not done CT or you think that ultrasound, and sometimes if you go which is not correct, suddenly ectopic kidney can occur. Suddenly ureter may be going to the opposite side. In such cases, one simple trick is, before doing the procedure, anyway you are doing ureteroscopy, do dilute contrast RGP so that you know the roadmap where it is going, so that you will not do any mistake. See, such type of abnormal kidneys, crossed ectopic kidneys, united kidneys may have different type of. That's why in the first sentence I told that RIRS is more road concerned with ureter and calyx, not with the parenchyma. If you can go into the kidney through a road, then doing the lacing is same. Now this is the calyceal anatomy. It may not be so important, but when you have multiple stones, one here, one there, you may miss. In that case, which is anterior, which is posterior, which is below, which is up. If you have three-dimensional idea like this, if you go to the CT console, it will give clearly the idea so that you can go to the spot and remove. If it is a single stone in the pelvis, there is no need to worry about this. Now coming to the inferior calyceal stone, lot of people will ask, sir, should we do inferior calyceal stone or not? What size we should do? Simple answer is, if your flexible scope goes easily into the inferior calyceal stone. What is that easy? Easy is the angle. What angle? Infundibulopelvic angle. How much it should be there? More than 30 degrees. If it is an acute angle, it is difficult. Usually, narrowness is not that much because flexible scope is only 7-8 French. Angle you cannot change. Angle also, IVP may not be able to tell. Like in RGU, if you underfill, you may interpret wrongly. Similarly, in IVP, angle may look acute, but in RGP, it looks different. It distends. That's why, if you are feeling that you can remove the stone from the inferior calyx, go gently and pass. In passing only, you are spending too much time. When will you remove the stone? Unnecessarily, you will break the scope. So simple idea is that tell the patient that I will go and see if I can easily reach the inferior calyx, I will do the RIRS. If not, I will do mini-per. Take the consents for both. Don't be dogmatic that, okay, I will try, it will come. See, your scope may get damaged. You may remove the stone, but if 10 dots come, what is the use? So size large stone, acute angle, not good for RIRS. And pelvis also, see, if you remember, RIRS and PCNL are opposite. If you have a large pelvis distended, PCNL is very easy, but RIRS is difficult. For example, in the middle picture, the stone will be moving here and there. Then how can you focus? Larger fragments will form. Each one you cannot go. In the sea, you have to swim. Then it is difficult. Now coming to the bifid system, sometimes you go into the one system, you have a stone, but you don't see into it. What is the trick is that if you are seeing only 2 calyces, think that something you are missing. You should see minimum 3. And if your angulation is closing the calyceal system, that means something is dividing upper and lower. Then come back carefully, look for another hole. Sometimes edema may not be allowing it, do RGP. That RGP also better do from the mid-ureter part, so that any 2 ureters you can identify. These are common. In CT, how to identify these two ureter is in between the calyceal system, parenchyma will be without any PCS. Then you have to suspect bifid system. Now, vessels, usually in RIRS, you are not going to touch the vessels. This type of anatomy is required for PCNL, not for RIRS. Why? You don't poke into the parenchyma in RIRS. Your aim is to do the stone only. One condition, you will poke the parenchyma. Where? Diverticular stone. In that diverticular stone, now latest is don't cut in one area deeply. It may have vessel. You cannot say exactly where the vessel come. Nobody can tell that here vessel will not come 3 o'clock, 6 o'clock, that will never work out. If you go deep, any vessel can bleed. Small bleeding in RIRS can hamper the vision. What the latest is, 4-5 points you take, each point you touch, then 0.4 mm you burn, overall diameter you increase, you go into it. Otherwise, primary diverticular stone with injection of the methylene blue contrast is totally different. But if you are seeing the stone, if you want to enlarge this lumen, cut 2, 3, 4, 5 areas, small, increase, not one area big cut, because it may bleed. Once that bleeding, it's like PCNL bleeding, maybe more in infundibulum. So at infundibular region, do not cut with homium because it's a knife. So roadmap is important for RIRS. Roadmap is very, very important for RIRS. Sometimes when you are doing first time, like it's a navigation, you are going to your house first time, you use navigation. Then every time you don't use, after 50 cases you don't use it. You know how to left and right and go in the road. Like that in this video, you inject RGP, contrast. If you are going left, it will tell, no, you have to go right. Then you will go right, so that your movements are not disturbed. You can quickly say, oh, this side is the stone, or this side is the inferior calyx, go that side. But don't inject thick contrast, because contrast is a dense medium. After that, lasing with contrast dense medium is difficult. So that's why dilute contrast so that it can wash off easily. Don't inject the dense contrast. Now these curvatures, you know, ureter is not in one direction. It will go up, down, right, left. One important tip is to, instead of traveling here and there, you make it straight. How? Pass a guide wire, everything will become straight. Over that you thread the ureteroscope, so no ginget of moving up and down and damaging the scope. This is very important tip and trick for all the youngsters. Pass a thick guide wire into the pelvis under C-arm. You thread the flexible ureteroscopy over that. Once you are in kidney, take out the guide wire, or say you do the lacing of the stone. So all the curvatures with difficulty, if you are doing, scope may break, particularly in a tight ureter. Now coming, this is the first part where anatomy and related parts. Now indications. Indications, again, it's a theory. Everybody knows that the guidelines are going. I quickly go through because every book, every chapter will give this. All the cases in indications, less than 15 mm stone, wherever may be the stone, AIIMS guidelines have indicated RIRS. All this is EAU guidelines have said the same, strong indication. They write URS. URS means both URSL and RIRS. Now RIRS is called, in fact, in Western countries, FIRS, flexible ureteroscopy, extension of ureteroscopy. You are going up to ureter, you are going into the kidney. So all the literature supports this. Now coming to the equipment, which is more practical. When you see simple equipment RIRS has, you need not go bang your head. Only 3-4 items are there. One is everybody want to know flexible ureteroscope. This is the flexible ureteroscope. What is the length? 70 centimeters. So when you want to dip in the chemical sterilization, remember 70 centimeter length box should be there. Don't keep the hand outside and then do the case. Not correct, because the hand one which you hold, that main control body which you hold every time is contaminating because of blood and everything. That should dip in the chemical. We use commonly chemical sterilization. So 70-80 centimeter length should be there. So there is one important point in this, distally 15 centimeter tip flexible. If you think that this is entire scope, this is the main important point, this junction. If this junction is damaged, see all the fingers move at this junction, main junction, main junction. This junction is damaged, this finger is no use. That way, when you pass a laser fiber, this finger should be straight, pass it and then bend. If in this position, if you pass, it will perforate here. That is very, very important. Now, various types of scopes you don't buy all these scopes. Why do you want to know? Like normally used scopes are standard, no conflicts of interest. Whatever available in the market, 2-3 scopes will be there. One disposable scope, 1-2 company scopes will be there. In depth, you know, all the size are 8 French only, all has 3.4 French channel, all are usually fiber optic scopes. Digital scopes are not commonly used. Don't think about digital scope in the initial, not very useful except a beautiful view, but double, triple the cost. But disposable scopes are digital, but we don't know how many hours, how many cases we can use it. So it's a different totally. When you use, these are the Carl Storch scope, these are the Pusen scope, this is Boston Scientific scope, this is Wolf scope, Olympus scope, all these scopes. This is a flexible scope, how it will be inside, why it is commonly used nowadays, because everything is plastic except chip on the tip. Everything is plastic. So future the cost will come down. Everybody wants to open a fresh scope for your close relative and do difficult case 2 hours and throw it out. I have opened entire flexible scope, nothing is there, only plastic except chip. You know what is the cost of the chip? Very cheap. Because in cell phone it is coming 10,000, very beautiful photos. Same thing come in digital scope. That is a change. Now coming to the, so flexible scope, remember, I will tell the movements also. Remember that they are very delicate. They should be kept straight. They should not be bent left and right. Channel is 3.4. So maximum 2.2 French accessories can be admitted. Other things, the 15 centimeter, that area which commonly damages, unnecessarily don't bend too much where it is not required. It comes with experience. Accessories. Guide wires, we all know there is no need to go. Termo guide wire is good. Zebra guide wire is good. The road runner is good. Anything which is stiff, it will make the access sheath go easily. Now, the guide wires I am slipping not much. This is the access sheath. Access sheath, there is one question already I have seen. Indian access sheath or outside access sheath. All is important is size, the smoothness of the access sheath. When you pass, there is nothing like Indian access sheath also can be used. More number of times if you use, they will become rough and it is very difficult to use. Access sheath most important is 2 types. Small access sheath, bigger access sheath. We want only smaller access sheath most of the times. How much size? 9 by 11. That is the only thing. What size? 28 centimeter, 35 centimeters, 45 centimeters. Standard question. Most of the Indians are average height is 5'7". So 28 or 35. You need not keep in the pelvis. If you keep in the pelvis, flexible scope does not bend. Simple. So 28 centimeter I use more commonly. 35 is more used, but 45 is very, very, very rarely used. Unnecessarily, we need not worry about that. Now, one more important thing is that the smaller access sheath, ureteroscope, the 4 by 6.5 ureteroscope snugly fits. Sometimes it helps in passing the access sheath in a difficult cases. Just for the knowledge sake, 4 by 6.5 ureteroscope snugly fits into 28 French access sheath. I hope you will sometimes utilize this high bladder neck or tight ureters, you can pass. Rest of all theory, ureteric dilatation, please do not do ureteric dilatation is my advice. Because forcible dilatation only makes it mechanical, but elastic will not happen. Elasticity of the ureter brings the water out. When you go with flexible scope inside, when the water distends, when it comes down, only because of elasticity of the ureter, not because of the access sheath. At some point, ureter should distend with water and the water should come down. If you forcibly dilate, ureter may not distend, then the purpose will not be served. I am telling you, one most important tip in flexible ureteroscopy is water coming out of the access sheath. Then only you will have a beautiful vision. Always aim, that I will show. This is access sheath from the Boston Scientific. Cook also has access sheaths. Any company you can use. There are no there is nothing. See, this is the way you insert the access sheath. Have a thick guide wire, always use the C-arm, then you pass slowly. Don't force. Buckling should not be there. It should be straight. Especially buckling happens at the bladder neck. Then withdraw. Again put the guide wire. The slow and steady always better in such miniature, when you are using miniaturized equipment. Unnecessarily at bladder neck, if you flex, scope will damage. These are the tips and tricks how not to damage the scope. See, this is the method I was telling. 4 by 6.5 scope nicely threads over the access sheath, over the guide wire. See, you go inside like this, have 2 guide wires, and now big ureter opening up nicely. Now you are going with ureteroscope. After that you pass the 2 guide wires are there, very safe. And again the scope is introduced, sheath is introduced and with under the guidance of the scope. Never ureter gets damaged with this, but only problem is only 4 by 6.5 scope over the 28 size snugly fits. That is the only limitation. If the water is coming out like this nicely, you can do 1 hour, 1.5 hour also ureteroscopy. If it is not coming, think once again whether access sheath is in proper position or not, whether ureter is distensible or not. You have to see all the things. Now, I don't want to go into the theory whether to use it or not. Remember, access sheath is only to get the water out. If you don't use it, water will go into bladder. You drain the bladder. The most important is not the access sheath, it is the ureteric distensibility and size. When you are passing the scope, if ureter is nicely distending, access sheath not necessary, but only problem is when you come out, again to go in, it takes lot of time. So no coming out if you are not using access sheath. For example, basket you want to come out. If you completely dust it, enter, and after 1 hour exit means no access sheath required, but bladder has to be drained. Baskets. Accessories in baskets, no too much confusion. Better not to use basket if the stone is seen nicely. Why? You make powder. Baskets are costly. Again and again you have to take out. Water vision will disappear. If at all you want to use basket, 2 conditions. One is inferior calicial stone, you relocate. When? Small stone, not big. Big cannot be taken and it may not come out. So less than 1 centimeter freely moving, you don't want to flex and do for a long time. Put a basket and take. What basket? Encircle, engage and Dakota. 3 baskets are there. These are given here. Encircle only point is widely opening basket if you take 2 centimeter. When you want to remove it, easily it will remove. Narrow you take, it will hold, but if you don't remove, what will you do? You have to cut it. So widely opening, you can open small only, hold it. When you are releasing, widely open, it will come out. So 2 centimeter widely in between these fingers, 2 centimeter should be the opening. You should ask 2.2 French, encircle, widely opening, 2 centimeter wide opening. But the engage is like holding it. It may not hold a bigger one because gravity it will relieve it. Sometimes it is not possible. See, these are the encircle, encompass. Dakota basket also recently has become very famous, where it will hold small stones. You can take it out. Small stone. Advantage is that you can easily release it. No entrapment. No entrapment. Whenever you want, you can release it. So baskets are only 3: encircle, encompass, engage, or Dakota. The most important encircle and Dakota. Dakota is like a tri-prong, but not that sharp. Adapters, you can use whatever adapter like in urology, not big. Irrigation pump, no. Why? Because in irrigation pump, high pressure will be generated. Laser fiber, very simple tip is small fiber, small fiber, small fiber. 200 micron fiber, water flow will be very good. You can have flexion better, you can have vision better. No discussion on that, because same amount of the energy can be delivered with laser. Now laser, you cannot talk in 1 hour about the laser. Normally used lasers are 2: holmium laser, thulium fiber recently. Holmium is a well standard. Thulium is also showing promising results. That is up to you choice. The important, everybody asks, sir, what laser I have to buy? Most important is holmium. 30 watts is sufficient for stone. But that may not do prostate. Very good for stone, up to 2 centimeter also. Thulium fiber, if you wanted to do prostate enucleation, along with RIRS, it is useful. 60 watts. That is my experience. Otherwise, individual pluses and minuses always will be there. Holmium will be very big mission, thulium will be small mission. Holmium chipping will be very good, thulium powder will be very good. Popcorn will be very good with thulium fiber, whereas holmium painting will be very good. Vision will not be disturbed. Regarding the heat, both generate heat. We don't have any documentation that one is better, one is less. So 30 watts holmium or 30 watts, 60 watts thulium fiber is enough. 200 micron fiber, enough. That much you have to remember. Which company, what, you decide. But 30 watts jada you don't require, actually speaking. Holmium YAG laser, this is the tips, these are all theory. You remember one point, when you are using flexible ureteroscopy, if the laser fiber is seen with your eyes, that means it is already away from the lens. Don't worry. 1 centimeter away already, because it's the hole will come a little farther, so that if you pass the laser fiber, if it is seen, means it is already away from your lens. Now coming to the laser settings. Lot of questions are asked on laser settings. Honestly, listen carefully. Before even showing the slides, theory is different. Energy, frequency, pulse width, modulation, that combination, that combination. One thing I will tell, whenever you buy a mission, you have energy settings usually 0.5 to 1. Frequency settings usually 5 to 20. So you try lowest energy, lowest frequency. What? 5 frequency and 0.5. That means 2.5. It is not breaking. Increase the energy. It will become 0.8. Slowly it is breaking. Increase it to 1. You rarely require more than 1 energy. So what is ideal? 0.8. 0.8 is ideal. But you should not say every time I use 0.8. 0.5 to 1. Frequency is around 5 to 20. That's all. Too much discussion, too much on the remembrance is not required. If you increase frequency, energy, both, stone will go away. Naturally, you are hitting again and again with large force, stone will away. If you want stone to be there only, medium energy, medium frequency. If a stone is in a room, you want to hit left and right, very fast, increase the energy and frequency. That's all. In the pelvis, if you hit, it will go there, again you have to go there. It will go here. So medium energy, medium frequency. Retropulsion, wherever it is there, you cannot proceed. Whereas in a calyx, one calyx is there, one stone is there, it cannot go anywhere. Marrow, high energy, high frequency, you hit it, it will become pieces. At the end, you do popcorn. So ultimately, dust will come with medium energy, medium frequency. In popcorn, if the vision is good, you can increase the energy and frequency. Both the cases, when the stone is very large, you can keep very high energy frequency, it won't break into pieces. It will become powder only, because that strength 30 watts cannot do it. So in the beginning, you use high energy, high frequency. As the stone size decreases, you decrease so that they won't become pieces. In pelvis, they become pieces, you have to chase the pieces. Whereas in calyx, it becomes pieces also, no problem. Where will they go? They will be there only. Again make pieces, they will become small. That small is nothing but popcorn. When large piece, it is called fragmentation. When small piece, it is popcorn. Dust is when you keep on layering. Ultimately, dusty banna. When you become popcorn, or when you large stone fragmentation, anything, last point is what? Make it small. That's all about laser settings. I will quickly go through it. This is the energy. That means how forcibly you hit is the energy. If the energy is more, it becomes pieces. If you want to make fine dust, you can't have high energy. Frequency, how many times you are hitting. So more times you hit, more small powder. So high frequency, low energy, fine powder. Medium energy, high frequency, popcorn. So in the beginning only, if you hit fastly, then it becomes pieces. You cannot do it. But in a calyx, I am telling you, purposefully you wanted to make it pieces, make it. You don't want to paint, you don't want to waste time. For 10 pieces, 20 pieces, 80 pieces, 100 pieces, 1000 pieces, then powder. The high energy, high frequency. So there are no fixed settings. You just play with your only 2-3 settings you play with is 0.5 to 1, 5 to 20. Increase, whichever is comfortable, stay there. 5 cases you can adapt to your mission. That's all. Now you see here, these are the various techniques. Dusting, see here it is a beautiful dusting method. In this dusting, you keep on moving on the stone. You can't keep very high energy here. Keep on moving on the stone. Dust will form. Or one paper, in a book, one paper you have to remove. So that last paper, you should come from periphery. But first paper, surface. Second paper, surface. Last paper, eat like a rat all around, and last part you take out with basket. Perfect. That is, takes time and experience. Chipping is this. On the edge you keep on chip. Small. Wherever you do. Surface also chip, edge also chip. What is the advantage? Little faster. Fine dust, if you want to make, lot of time it will take. Chipping, you can edge, chip. Small chips will form. But that is not golden sand. It is fine sand, rough sand. Popcorn is when small pieces, don't see the stone, center you keep it, activate, they only will come in it like in a popcorn. If you keep 4 minutes, they will become small. But no single stone you are hitting. 100 are coming to you and hitting. But repeatedly hitting, they become small. You need patience. What patience? How much time? Till you see powder. That is called pop dusting. Their energy frequency is very important. But if you increase too much energy and frequency like 120 watts, your vision will go. This is the popcorn. Classical popcorn. This cannot be done in pelvis. This can be done only in calyx. Pelvis, here and there they will go. In a single room, if 10 people will beat, immediately the stone will become very small. So closed room, popcorn is useful. Their energy frequency can be increased. Fragmentation. You want to deliberately fragment, make it cut, diamond cut, designer cut. You want to make 4 pieces, bladder, take out 4 pieces. Like here, vertical cut I am giving. So don't use more frequency, high energy, low frequency, cut, center it is cut. 2 pieces. Again cut, 4 pieces. Now exactly center 2 pieces out. That piece you take it out. Why you want to make powder in the bladder? Fine powder, what is the use? That is the popcorn settings. Now this is the fragmentation. Fragmentation is you want to make pieces. You make fragmentation. So one important point here is, everybody talks about pulse duration. Short pulse duration is for this fragmentation. It fragments 1 piece, 2 pieces, 4 pieces like that. Short pulse. Long pulse duration for everything. Popcorn, dust, incision, coagulation, everything. One simple word. Long pulse duration for everything. Short pulse duration is only for the fragmentation. Large stone, faster. That's all about the laser settings. Now coming to the sterilization, there are only 2 methods. One is chemical sterilization, steroid. Chemical sterilization is what you dip in Sidex or Paracef. This is the box you should buy or you should make. Long box, thickness less. So you put Paracef for 1 day or Sidex for 15-25 days. Chemical sterilization, there are problems. Not recommended, but practical. Only thing is that rinse properly, dry it properly. Rinsing immediately after the case, drying immediately. This is to be done by surgeon only. Because it's 5 lakh scope, if somebody technician doesn't know, suddenly roughly handles, or one technician you train. Everybody says this. Like you might have already experienced that in your theater, these things are done. Steroid we have recently taken. In this system, you have to dry it, you have to make it clean, and blood and everything should be cleaned. But our feeling that last 2 months we are using steroid, where significant decrease in the infection rate has come. This is for cases when you are doing 5 cases, 8 cases per day. One scope only if you you cannot sterilize with chemical properly. So technique, tips and tricks, this is the way you hold this is important for the juniors who are taking. This is the way you hold the scope. This is not the way you hold the scope. You cannot put all the scopes like this. I was telling the finger here, don't perforate because this is a flexible angle. Always check the laser fiber integrity. Green light should be seen only at the tip, nowhere else. Patient related factors, read this carefully. 10 cases you do just post-stented cases, only diagnostics. Then you feel good that my scope is used. Young female is better than old male. Single stone less than 1 centimeter is better. Recurrent stone formers don't take, they will blame you. Access the ureter with ureteroscope always with RGP. Initially select upper calyx stone, straight it will be there. Why unnecessarily struggle? You have feeling that you have completed 20 cases nicely. Then you bend. Patient related factors. Inferior calyceal stone always try to relocate. Large pelvis avoid. Hard stones avoid. Big stones avoid. Preferably do under general anesthesia. Very large prostate gland avoid. Keep the respiration at low tidal volume. Staged procedure. Tell the patient that again I may go inside. Not many people will accept, but tell it. Tell it, you charge accordingly, divide the charges so that they will accept. You can't charge both the times like that. You should go according to your local charges and then explain them and help them also. Like this. This is the relocation of the stone, where stone is all around seen. Then you have the basket and you go and put it in the upper calyx, and then when you are putting upper calyx, you should push it like this so that where you are going, you should be able to know. That's it. Respiration, if you do too much respiration, you cannot concentrate. Every time it hits the mucosa and then you will get the problem. Now, flexible ureteroscope irradiation factors, too much bending avoid, laser tip close, don't keep it, less energy is better, 200 micron fibers is better, don't push the stone with flexible scope, always clean it, dry it and then sterilize it. You see here, lasing tip position, Plex X2 on the left side and digital scope on the right side, both are doing fine work. If the stone is more on this side, 3 o'clock position, you use that. If it is more stone on the 9 o'clock position, but you cannot buy 2 scopes, a little bit bend will do the purpose. Irrigation and accessories related, already I told, always manual irrigation with syringe is better or gravity is better, but pump preferably avoid because it generates lot of, what is the pressure generated up to 40, 100, 200, 300, 400 rupture. So why unnecessarily go and continuously increase this? One question has come, just I was seeing, should we stop the irrigation in between? Don't stop it. Even while loading the guide wire, you don't stop it. You continuously doing it so that water will be coming out, blood will not form. RBC also will form a clot and suddenly you lose the vision. And 2.2 is the large size you should use. HD camera and UPS. UPS also important because when current goes and comes in India, it is very common summer when you are doing more cases, suddenly light will come into a stop. So inside chips will go. Current goes, no problem. When current comes, you should control. So if you don't have UPS, when the current goes, switch off everything. Then when current comes, again you switch on. At least that is better. That's important. So never use maximum energy of the machine for a long time. Because if you use the computer for a long time, phone for a long time, it will get heated up. Same thing will happen with the machine also. So here you see small perforation, suddenly slowly blood is coming like this. That may be a infundibular vessel also. I have seen bleeding in infundibular vessel also. Be careful with that. Now too much laser fiber outside like this cannot. Somebody was asking a question, viral full effect. If viral full effect is nothing, no infection, nothing. It's a powder. Powder, you come out, powder will come like this, like a water, round water. 2-3 times you come out, all the powder will come out. Why the infection will come? Water should be coming out, vision should be good. So no infection. So cost effective, how to do cost effectively RIRS, everybody, sir it is costly, sir, patient cannot be consumed, PCNL is just 5 minutes. I am telling you, if you become experienced and once you do 100 cases, your scope damage will not be there. First 50 cases go to a center. For example, we are doing every fourth Saturday free workshop where you can come to the theater, you can see 4 or 5 cases, you can see all the things. When you see in a screen in a live workshop, it is not possible. When you go to the theater and see, you clearly know how you are standing, what pressure is giving, what guide where, practical problems will come. Every fourth Saturday we are doing without any registration. Many people are doing, you go there, you 2-3 times you go, then buy the scope, and post-tented cases only you do it, and small stones you select, then it becomes cost effective. What is the most dangerous? Laser mission will not get damaged so easily. Laser fiber also, if you are careful, will not get damaged easily. Only flexible scope. Handle it carefully, or else buy digital scope for some time and try. But problem is digital scopes are large. All cases have to be stented. So normal scope also you can use 40-50 cases, then it is cost effective. Definitely PCNL you cannot compare, but it's okay. Now last 2-3 topics are there. Approach to the simple cases. Whenever you have a impacted stone like this, you go inside and try to push the stone. Try to push the stone into the pelvic system, and then otherwise you do like this. Center. Don't touch near the wall. Center of the stone you make pieces. Concentrate on the center so that heat will not go into the wall. Only center. That's all. Ureteric stone preferably avoid. If you wanted to do it, center you make it through 3 pieces, push into the kidney. Otherwise pneumatic lithotripter, take it out better. Now simple upper ureteric stone, you just go inside like this, just go inside, see the stone, don't break anything there, push it. I will push it and do RIRS. If you are very confident, about the lithotripsy, that time also it can go up. Don't worry, if you have a flexible scope, you just push it up. For example, here I am going inside and gently pushing it up into the kidney. Go inside like this, once or twice it has gone inside, and do the flexible ureteroscopy. Impacted stone bifid system. This is the impacted stone bifid system. Here also sometimes you have to break it there only. It is difficult situation. See, bladder neck is high. See, you are going like this and you have gone into the upper calyx. Suddenly these are the pulsations you are seeing here. See, there are 2. One opening here, you have gone there, you have not seen anything, and again you come back, you see below, see, there is a small. Now you are using the flexible scope. In rigid scope it may be difficult. Now you are going in, see, above is 1 and below is 1. Above you have gone, there is no stone, you are confused. Where is the stone? Now you come back, see, only one calyx is seen. Now you come back, suddenly there is a dip there. See, there is a stone. These are the difficult. See, that is impacted stone. Try to push it. Here you will lose the scope. Be careful. These are the cases you should be very careful. So then inferior calycial stone. I am talking about simple cases only, not complicated cases. So you go inside and carefully see the stone, keep on moving slowly, keep the low energy, low frequency, and then do powder like this. It's very easy. Once you do 30-40, push back RIRS. As already I have told, any stone which is there, see here you are gone, stone is seen, voluntarily you push it, it has gone inside. Now it has gone inside. Now you take the flexible uteroscope and do proper RIRS. Now, see here, classical painting with both thulium, and everybody asks how is thulium, how is holmium. You see in this 1 minute video, slowly you touch, make it powder. Slowly you touch, make it powder. Both are same. It is very difficult to say whether this is thulium fiber actually. Only thing is that thulium fiber makes fine dust, and whereas chipping is better with the holmium. Sometimes fine dust takes long time. Popcorn it is better. So we have finished 45 minutes of time. Another 15 minutes is there. Another 5 minutes I will close. Last 10 minutes we will read the questions and we will answer. Now you see here thulium is like this, and now coming to this is the holmium. This is a classical painting. Ideally you should do like this. Slowly chip, come from periphery, from the top. Don't be in a hurry to make 2-3 pieces. Then results will go. This is the classical method how you have to do careful powdering. It will happen. Energy first keep low, then keep on increasing. Now multiple stones, long infundibula like this, upper calyceal stone is very easy, like this, like this. You take the basket, already we have shown, now basket is opened, and then you put it in the upper calyx like this. Siam picture you see here, it has straightened, that's all. Lower calyx, one stone may be like this. See here, RGP, you go inside and see the stone. If it is seen, what is the problem? You can just see this is the stone, directly accessible, you do it. Now complex cases, we have done a 4 months baby. This is just to say that, right, basic to the proper approach. These type of cases you should not do in the beginning. Small babies, obese patients. I am just showing that after doing 3,000, 2,000 cases, we can go to this small baby. See how we supra catheter kept, small penis, and ureteroscopy is done. This maneuver is used. See quickly we have gone inside. See very difficult. Everything should be careful. Siam should be used less. Now I am inside. I am powdering the stone like this. Small capacity pelvis. Immediately we have done on the other side also. Very difficult entry. See the stone is coming out and going out. Narrow pelvis. You can do it. This is in fact published in Elsevier articles. This is the smallest baby available in the literature in the world to go for bilateral RIRS. Experience, you can do it. Now 3-year female child, one side operated outside PCNL, bleeding, clot formation. See, very good stone for PCNL also, but in children it can bleed. But when we did RIRS like this, very long length will be outside in children, then is a female child, then we could complete it. See, I just roll it where we have done. See, we are aspirating from above so that the bladder cannot be, we have to continuously monitor the pulse rate. See how nicely, slowly we are chipping in the upper ureter only, and carefully without damaging the ureter, and to remove all the pieces. Obese patient, see how obese he is. See, this is the obesity. How does it matter? Urethra is same, ureter is same, you go inside, you do like this. These are very useful cases. This is ectopic kidney, doesn't matter. You go inside, and then these are advanced cases. Don't try in the initial level all. This is only to say that after certain experience you can go for a larger stone, ectopic kidney stone. See, this is the way access sheath is inserted, and see very large stone, water is coming nicely. Then you are doing slowly powdering. Multiple, these are large stone, solitary kidney, you can do it. Staged repair, 3 times I have done it. This is a kyphoscoliosis baby where simple case for PCNL it is very difficult. All spine is like this, you may not be able to puncture, but in 5 minutes RIRS will be finished. Now this is a solitary kidney, diverticular stone, you can go inferior calyx and do like this. Isolated, see a totally 180 degrees kidney abnormally rotated. You just pass the scope, you see the stone like this. In this case, easily stone is seen like this. And what is the problem? Happily you can do it. This is a crossed ectopic kidney, post pylolithotomy, post PCNL, residual stone is there. See how much bent I have done. But if you know that you are not flexing too much, it will not get damaged. Then it becomes cost effective. Now this is a crossed ectopic kidney, opposite side 1 centimeter. No other procedure you can do except RIRS. Like that, in advanced cases will be there. You can use all this technique. Pediatric horseshoe kidney. See, this is the horseshoe kidney. In this horseshoe kidney, what we have done, normally we went inside with an access sheath. Is a male boy, around 7 years. Penis will be small. You have to be careful. Don't damage the urethra. This is the last cases. Bilateral stone. Nearly 50 stones here, 50 stones here. What will you do? You cannot puncture 50 stones. You go inside. You see both the sides simultaneously done, post-stented. In such cases, you stent. You have nice outflow. You let the ureters will be very big. Both sides you keep on powdering, half an hour this side, half an hour this side. But relook. After 15 days, again you relook. So this is RIRS assisted PCNL. You have 2 stones. You take the 1 stone from below and keep it, and then 2 PCNL. Very good. Both stones are big for RIRS. You take the upper stone, and like this, you see, you go into the RIRS, you break the stone, you make all the stones bring into the pelvis, and then do PCNL and remove the stone. So no two punctures, upper calyx unit. Diverticular stones are there like this. Then you can do complications. This is the last talk, only 1 minute. Complications are if you use too much energy at infundibulum, torrential bleeding can occur. For example, you see here bleeding, see here bleeding, too much bleeding in the access sheath. Don't keep on seeing like that. Take it out and it will stop. It is slowly irrigation, immediately you keep, immediately it stopped. Now this, see how the laser fiber touching the guide wire and the ureter, it forms stricture. Then you cannot pass. Now, these are the high frequency energy, total ureter may get damaged. To conclude, RIRS is not difficult procedure. As a matter of fact, last 5 years, lot of youngsters have brought RIRS. When compared to PCNL puncture, 3-dimensional anatomy, difficulty in bleeding, RIRS only problem is if ureter is tight, put a stent. In 50 cases, take help and go to certain places and then do the cases. And you always go slow and steadily. As I told you, every 4th Saturday we are doing workshop, 4th Saturday, like 22nd, 23rd, this month 23rd, like that we are doing. It's a teamwork. We have now 7-8 urologists. Sometimes in difficult cases, we seniors will flush the system so that high pressure will not be generated. So it's a teamwork. Anesthetist also has to be cooperative. To conclude, RIRS is feasible. Initially go for training, buy the scope, do simple cases in the beginning, slowly increase the complex cases. Laser settings always keep low. Buy a laser which is less costly initially and use it so that you will do very well. Thank you very much. We will take the questions now.
Thank you, sir, for such an insightful presentation, and thank you for making things so simple for all of us. And so you spoke a lot about the fragmentation technique and the dusting technique, but still there are a lot of questions on which one to use when. So if you can throw some light on the various techniques for
If the stone is in the pelvis, reasonably big, paint it. Use medium energy, medium frequency, 0.8 and 10. Beautiful. Nicely you keep on moving. After some time you may push it into the calyx. That is one. If it is in the calyx, if you don't want to powder, high energy, medium frequency, make it to pieces and go for popcorn. That's all. If it is inferior calyx, try to relocate, or else you cannot paint easily, so make fragments. But too much energy will break the laser fiber. Medium energy, medium frequency. So all the answers are done.
Thank you, sir. And so actually a couple of questions on which scopes to prefer. Like should it be a scope with a bigger diameter, 9.5 French, or a smaller diameter scope?
See,
and in children, which one do we use?
Now, as of now, diameter small scopes are all 7-8 French scopes. You have to remember, tip will be small, but shaft will be big. All digital scopes are big. Pediatric scope, recently I used from Carl Starch, which length is less, 34 centimeter, but diameter is same. So, commonly used scopes are Flex X2 and P7. Other scopes are also used, but they are digital scopes. So, you choose among 2-3 scopes. There are no conflicts of interest. Newer scopes are coming, disposable scopes are coming. So, generally 7-8 size is better. Anything more than 9 size for beginners is not advisable.
And so you already spoke about how long to do the irrigation, but still there are some questions coming that should we continue it throughout? Or do we keep
irrigation has to be continued throughout. Only important is water outflow. If it is continuous, you irrigate. Water if it is not coming, think what's happening. That's all.
And if the orifices are narrow, can we dilate it with Nottingham technique?
Yeah, generally I told that it should not be done, dilatation, because elasticity of the ureter is also important. If you just gently dilate and go inside, upper ureter may not be distensible, then water will not come out. In such cases, it is not useful, and mechanical dilatation always causes some trauma to the mucosa. Put a stent and do after 12 days is most commonly recommended literature.
Yeah. And so there is a question that were there cases where RIRS could not be completed and it was converted to a mini PCNL?
Many times, many times, many times, many times, even by the seniors, always take the consent. You should be very good in PCNL. PCNL is a basic surgery. Sometimes very easy to take out the stone if you do a proper puncture. Never get carried away for large stone with RIRS. Unnecessarily you lose time, it go into sepsis and scope may get damaged. If you are not able to see the stone, if you are not able to fragment the stone, if it is easy for the PCS, go for puncture, no doubt. In fact, supine PCNL, if you know, easy, ECIRS, finished off. But always keep PCNL as a very good option, not like a rare option. Immediately think and do PCNL.
And so quite a number of questions on how do you navigate between the left and right? How do you do the hand movements?
Honestly speaking, left and right, no difference. Only thing is that medial rotation, lateral rotation. On the right side, pelvis will be on the right side, and the right side of the patient, the calyces will be there, and pelvis will be on the center side. So you will understand it. Instead of thinking it, do gentle RGP, see all the movements on which side you have to do, automatically your hand will do it. Don't too much apply theory on that. You do gentle RGP, if you are seeing this, if you tilt your head this side, all the calyces on the right side will be. That means your head has to be tilted like this, automatically external rotation. If your head has to be tilted this side, automatically internal rotation. That will come naturally, unnecessarily don't go for theory.
Sir, a couple of questions specifically on Olympus 6. How do we navigate with how should the movement be? Because they are saying the movement is restricted.
See, we are not going to talk about any company scope. Every scope has plus and minuses. P6 scope is withdrawn. P7 scope is there. P7 and FlexX2 both are good. In many respects, both are good. If you want to go into the detail, it is not the correct platform, but the FlexX2 has a small honeycombing effect, but more flexible. Whereas P7 has bright view, but little less flexible. But now newer scopes are coming, both are equally good.
And so you give example of ectopic kidney. There's one question for horseshoe-shaped kidney.
Yes.
How do we go about?
In horseshoe kidney, RIRS is feasible very much. We have done very good number of cases. Only thing is that large stone again problem. Lot of time will take. 1 to 1.5 centimeter stone, stent it, go inside. But one important factor is PUJ narrowing, high riding, narrowing of the PUJ should not be there. Water outflow should be coming freely. That's the most important point in ectopic kidney as well as horseshoe kidney.
And so which side of the table should they stand if they are operating on the right?
Usually right-hander will stand on the right side of the patient only, naturally, and screen will be on the left side of the patient. It's very difficult to stand on the other side and do it impossible.
So in the same relation, like how do we manage with the respiratory movements?
Yeah, that's a very important question. That's very important question because the anesthetist should say that reduce the tidal volume as well as the reduce the frequency also. But recently we have seen spinal anesthesia also that can be done, but patient has to be little cooperative. If the patient take deep breathing, you have to tell that you have to make him practice that slow breathing you take. General anesthesia is luxury. It doesn't mean that spinal cannot be done. Can be done. I prefer general anesthesia. Anesthetist will keep tidal volume at around 300 ml, respirate rate around 8 to 10. Then it is luxury. A light movement will be there. You can nicely paint it.
Yeah. So actually 3-4 questions on what is the maximum size of stone that can be removed by RIRS?
We have done approximately 3.5 to 4 centimeter stone, but not advisable. 2 centimeter is ideal. Less than 2 centimeter better. More than 2 centimeter there should be an absolute indication. Like coagulopathy, very difficult case for RIRS, upper calyceal, very difficult case for PCNL, upper calyceal stone, experienced person, post-stented, laser good watts. So generally 2 centimeter is the maximum limit if you are comfortable. The volume is also important. 2 into 2 into 2 is big, 2 into 1 into 1 is small.
Yeah. And sir, is access sheet required in all the cases and how frequently do you basket?
Yeah, I do not basket because I am a duster, so I try to make dust as much as possible. Only for relocation I use the stone. Important point is access sheath most of the surgeon use. Most of the surgeon use. Because one or the other time you may come out, again entry is difficult. But it is not compulsory. If the ureter is very wide, if you have good access, go inside over the guide wire, finish the case and come out, but bladder should be drained.
Sir, considering that the urine is sterile, what would be your choice of antibiotics?
Yeah. Normally, ceftriaxone sulbactam is the antibiotic I use. I am not using amikacin. Previously, I used to use, but after using steroid, our infection rate is significantly decreased. There is no problem. Your basic antibiotic is like third generation cephalosporin. Rarely in post case fever, we use piperacillin tazobactam. Very rarely we use meropenem. The percentage is 1%, 10% piperacillin tazobactam, 90% ceftriaxone sulbactam.
Sir, any recommendation for disposable scopes?
Yeah, disposable scope now commonly used. It's a very good question. They are little larger size. They are costing around 70,000-80,000 now. One time if you use for 70,000, nobody will use. If you use for 12 cases, how it becomes disposable scope? Sterilization is a concern. If they can be sterilized, you do it. If the company says that sterilize it and use for 4 hours, you can use for 10 cases and each case will cost. It is going to come slowly in next 5 years, especially beginners. Only problem now is larger size. You have to use larger access sheath. That is the only limitation for the juniors. Otherwise, it is useful because if you break, you lose only 70,000, not 5 lakhs.
Yeah, sir, actually 2 questions on complications. One which you have already covered. One is like how to manage clots and bleeding.
Yes.
And the second question is, what if there is a complete ureteric avulsion during RS?
These are 2 important questions. Clots if formed and vision is disturbing, put a stent and come out. Don't try to put more water, try more this and that, fever will come. One clot formed means RIRS cannot be done, or else you go for PCNL. Second question is important, ureteric avulsion, it is purely it's a disaster, should not happen first of all. Don't try to pull anything which is holding, especially basket. If avulsion comes out, tell the patient attendants that the complication has happened. Best way is to do PCN, but doing PCN in avulsion is difficult. Always local senior help you take without hesitation. Any senior you call him, take the advice whether to repair it, what level avulsion has happened. Uretron, you see, bladder can lower part it is better, upper part is not good. Don't go hurriedly for ileal replacement or bladder replacement on table. Don't do anything hurriedly. Minimum 2 seniors you contact, take opinion, sit down calmly and do a PCN with the help of a radiologist and senior urologist.
And so one more question we'll take. What do you mean by populating when you said in your session, and when to decide for pre-stenting?
Pre-stenting, when the ureter is narrow, 6 by 7.5 scope is not going, then pre-stenting is required.
And so one last question, which is stenting and later doing RIRS is better than a single time RIRS. What is your experience?
If the ureter is not tight, do RIRS but put stent. In India, better to put stent and take all the fragments will come out. If you don't put stent and high grade fever comes, again you go to the theatre, generally people won't accept. I am slightly favoring person for stenting, even pre-stenting and post-stenting. But if you explain the patients, short period, give some anticholinergics, they will be benefited.
Thank you, sir. So I think we covered most of the questions.
Yeah.
And
I am very happy that Sun Pharma is conducting such type of academic activities. Even I like to listen from next time any icon speaking on any subject. This is a great initiative. It's not the one person. They are taking seniors and they are going into the depth for 1 hour, and it is everybody can watch through their phone. It is one of the most latest method of transferring the knowledge, highly appreciated. I thank personally for giving this opportunity. I hope all the people who have watched will get benefit from my talk. Thank you very much once again.
Thank you, sir. And just
Thank
to
you.
highlight, we had approximately 600 logins,
Oh,
and
great.
600 urologists who participated in this program.
Fantastic.
And thanks to you, sir, for accepting our invitation and
Yeah, it's my
making all the
privilege.
discussions so simple for us.
Yeah, it's my privilege. Thank you very much.
Thank you so much.